Welcome to the Mastocytosis Society video on mast cell activation symptomatology. This video was funded by a generous grant from the lay organization of the American Academy of Allergy, Asthma, and Immunology. Hello, I'm Valerie Slee, Vice Chair of the Mastocytosis Society. I am also a patient who has had a systemic mast cell disorder for over 20 years. It is our hope that this video will help you to recognize the symptoms of mast cell activation in order to facilitate earlier diagnosis and more effective treatment of mast cell disorders. We present the expertise of 4 leading physicians in the study and treatment of these diseases. At times, these doctors will speak about the disease mastocytosis, as clearly defined by the World Health Organization. At other times, they'll speak about mast cell activation disorders, which fall outside the WHO criteria. We hope their expertise and their differing perspectives will contribute to your better understanding and to the diagnosis, treatment, and research into all mast cell disorders.
Mastocytosis is a disease characterized by presence of abnormal accumulation of mast cells in the tissues. Mast cells are integral parts of our immune system. We need them to fight off infections, but they are also involved in manifestations of symptoms of allergic diseases. They contain chemicals such as histamine and leukotrienes, and when they are activated, they release these chemicals into the blood circulation and into the tissues that brings on the symptoms of allergic diseases like flushing, itching, low blood pressure, and so on. And in mastocytosis, the bone marrow produces too many of these immune cells, and they get improperly activated. The patients often have problems with symptoms due to mast cell mediator release, such as unexplained flushing, itching, gastrointestinal symptoms, nausea, vomiting, and so on.
If a patient has mastocytosis, the number of mast cells is increased. And the increase can be either in the skin, and that would be what we call cutaneous mastocytosis or skin mastocytosis, or can be increased in the rest of internal organs. There would be an increase in the mast cells in the bone marrow, an increase in the mast cells in either other organs such as the gastrointestinal organs, in the stomach, in the esophagus, in the colon. It is also, there is an increase in the lymph nodes, and the lymph nodes can be either in the intestinal lymph nodes or in the pulmonary lymph nodes or any lymph node in the organs. And then the spleen and the liver can also have mast cells.
This disorder is not well recognized. It's not written up extensively in textbooks. You go to places like Up to Date or to certain books, it's there. So when people who have mast cell problems go to their doctors and say, "Doctor, I'm troubled, I don't feel right. I have these headaches and I flush and I get belly pain." So the doctor might think, well, maybe that's carcinoid syndrome, which can also give you flushing. So they do tests to measure for carcinoid syndrome. They're negative. So the patient goes back to the doctor and the doctor says, "Well, you don't have carcinoid." He says, "But doctor, what do I have?" And so that fact means that many physicians who are not aware of the many subtle manifestations of this disorder miss the diagnosis, and many patients with mast cell disease will tell you, "I've been to 4 or 5 doctors, I've had these symptoms for 4 or 5 years, and it wasn't until I saw Dr. So-and-so that they put it all together."
The most common symptoms we see in adult patients are flushing, abdominal cramping, diarrhea, nausea, vomiting, sometimes lightheadedness. A subset of patients may present with recurrent loss of consciousness, lightheadedness episodes progressing to full loss of consciousness, which may resemble anaphylactic episodes. These symptoms may be triggered by heat and exercise, sometimes emotional stress, sometimes alcohol and spicy foods. So these patients may be diagnosed as having idiopathic anaphylaxis, but when we look at their bone marrows, we show these abnormal mast cells that really indicates that it is the clonal mast cell population or mast cell disease that are causing these anaphylactic symptoms in these patients. One of the biggest clues to the presence of mastocytosis is a skin lesion called urticaria pigmentosa. So in any patient with suspected mastocytosis, a good skin examination is essential. So these lesions look like freckles, and they have a brownish color, and they are fixed. They don't come and go like a regular urticarial lesion or hives. They are there all the time, and they are not necessarily pruritic or itchy at the baseline, but if the patient takes a shower or exercises, then these lesions may start itching.
We see what we call dermatographia, where you scratch basically the skin and within a few minutes you get a welt looking, it's like someone flogged you, which can remain for like hours. Recently I saw a patient in Europe who's actually a medical student who has had all the problems we've been saying, but more so a symptom that I left to mention at the end, which can be classified as a neurologic symptom. But he was saying, for years now, I just cannot focus, I cannot study. But I said, if I were to describe something called brain fog, would that describe your symptoms? He said, my God, that's exactly it. It's like I have a fog all the time, I can't concentrate. And that's exactly, and I said, do you mind if I just scratch you? And I scratched him, he got a welt that he's never seen in his life. And he turns out to have mastocytosis.
The major WHO criterion for diagnosis of mastocytosis is presence of 15 or more mast cells in clusters in bone marrow. In addition to the major criterion, there are 4 minor criteria. One of them is a tryptase level. The second minor criterion is the shape of the mast cell is abnormal in mastocytosis in comparison to a normal mast cell, which is because they have an abnormal gene, which brings us to the third criterion, which is the mutation in the c-KIT gene at codon 816. And finally, the fourth minor criterion is presence of an abnormal surface marker called CD25. The marker that is most commonly used to indicate mast cell degranulation has occurred is tryptase. It needs to be measured within 4 hours after mast cell activation, and it needs to be compared to the patient's baseline. If the tryptase level is elevated over the patient's baseline after an episode, then that is a very good indication of mast cell activation. And the higher the tryptase level, the more chances that the diagnosis of mastocytosis is correct. However, a normal tryptase level do not necessarily rule out mastocytosis. We have seen many patients with tryptase levels within a normal range, and in those patients the diagnosis could only be established by a bone marrow biopsy and aspiration by demonstrating the abnormal clustering of mast cells in the bone marrow.
If a patient comes in with symptoms that are reminiscent of allergy, that involve more than just one organ, more than the lungs, for instance, to me, it's already a flag that we might be dealing with more problems. You add gastrointestinal problems to that, it becomes hotter. You add actually neurologic or bladder problems, you're burning hot. And that's how I would go at it. And I would not send a patient away to another colleague before at least myself or through one of my colleagues do the 24-hour urine test and at least a serum tryptase. And the reason why I prefer the 24-hour urine is because that collects the molecules that we're looking for over a period of time, while tryptase goes up and down within a couple of hours. So you just might miss that episode and you'll never know.
Mastocytosis can be diagnosed at any age. We usually see 2 peaks. One occurs in children, usually within the first 6 months of life. And these patients have a benign prognosis, usually. They grow out of these skin lesions by the time they reach adolescence. The second peak occurs in around the 4th and 5th decades of life, but it can be essentially seen in any age.
Sometimes I get a bellyache. I feel a little itchy and a little red.
Living with a systemic mast cell disorder is extremely difficult, primarily because of the unpredictability of the symptoms. You can feel perfectly fine when you get up in the morning, dressed to go somewhere, and as you're going out the door, you can suddenly get chest pain or abdominal pain, and your plans are waylaid. Definitely the abdominal pain, bloating, and diarrhea are the ones that interrupt my life most frequently.
In the last year or so, I've been able to eat pickles and anything fermented. Peppers have become a trigger for me. And it's kind of an adventure, you know. Sometimes you can get by with a little bit, but the next day it'll hit you. Sun has been a trigger. Heat primarily more than the sun. Sun will kind of make you itchy, but the heat itself will make me lightheaded, nasally, and if I'm in the heat too long, I'll get achy and tired and just unable to think very well.
I was diagnosed with mastocytosis as a result of hives that I had for probably about 3 or 4 months before I was diagnosed. Hives all over my body, nausea, I always, flushing. I couldn't stay at work. I couldn't stand to be hot. I was extremely tired. It's a roller coaster of symptoms, and you never know where you're going to land.
I went and visited an allergist who's now retired, Harold Freeman, up at Dartmouth-Hitchcock, after these anaphylactic episodes. And he tested me for stinging insect allergies and found that I basically was free of any kind of allergens to any stinging insects. He said, I think something else at play here. He says, how long have you had that rash on your skin? And I said, I don't know, 5, 10 years. Why? He says, what is it? And I said, well, I was told it's chronic hair follicle infections, folliculitis. He says, I don't think so. And the whole dermatology department at Hitchcock came and massed around me, and they weren't scratching my body and trying to check out what was going on. And in the end, they did a biopsy of one of the lesions, and it was mastocytosis. They could see hundreds of times the amount of mast cells in there that would normally be present.
And one very important aspect of management of mastocytosis is prescription of self-injectable epinephrine. Even if the patient has not experienced any anaphylaxis, unless there is a good reason not to prescribe epinephrine, I usually prescribe self-injectable epinephrine to all of my patients who are diagnosed as having mastocytosis, because symptoms of anaphylaxis or loss of consciousness, syncope may occur without any precedent in an otherwise asymptomatic patient.
So we concentrate on blocking the mast cell mediators. The blocking of the mast cell mediators is at 2 different levels. The first level is at blocking the release of those mediators from the mast cells. We give a compound that's called sodium cromolyn, and sodium cromolyn can be given in different forms. It can be given orally, it's called gastrochrome, or it can be given an inhalation, it's called Intal, or nasally, nasal chrome, or ocularly. So there is many forms in which this compound can be given, and this compound has been shown to have very strong properties at inhibiting the mast cell mediator release. The second line would be to block the receptors of the mediators that have been released.
We would direct our treatment towards the offending chemicals. For example, we would use a histamine H1 blocker to block the effects of histamine on H1 receptors. And those would be traditional antihistamines, which might be Allegra, Claritin, Zyrtec, Benadryl, which block that receptor. We'd use a histamine H2 blocker, and popular ones there are ranitidine or Zantac. Those would be the initial things that we would do. If we were having trouble controlling the patient, we would use incremental doses. We might add a leukotriene inhibitor like Singulair. But let's say we have a patient that has some of the findings. Let's say they have dermatographism, alcohol intolerance, abdominal pain, and they flush. But you measure all the things that relate to mast cell disease, like serum tryptase, urinary histamine. They're normal. I would then embark, because I think there's a reasonable chance that they have a mast cell related disorder that's below the threshold of diagnosis. I would then start that patient simply on an H1, H2 blocker and see how they did. If they were to tell me that they felt dramatically better, I would continue the treatment.
And then we have some other histamine 1 receptor antagonists that are not available in this country. One is a drug called ketotifen. Ketotifen, in addition to being a very good histamine receptor antagonist, also has some weak ability to block mast cell release, and it also has fairly decent ability in blocking the infiltration in various organs of another cell called eosinophil, which also participates in many of the symptomatology of the patients. And finally, there are some natural molecules that belong to the class that are called flavonoids. These are found in green plants, in seeds. There are about 3,000 of them, but some of them, 2 or 3, are very good in blocking mast cells. In fact, we have a series of publications that in the laboratory, they can block mast cells 100% of anything they release. 2 of those that are very similar are called quercetin and luteolin. And I'll stop with that. Quercetin is found in the pulp of grapefruit in large quantities, while luteolin is very rich in olive oil and olive seed oil.
There is a subset of patients in which we would do a bone marrow biopsy, and the bone marrow biopsy would not sustain the criteria for systemic mastocytosis. In addition to that, there are mediators. The ones that we have available would not be elevated. And so that would pose a problem to us in terms of what is the name that we give to those patients. So there are several diseases that have been associated with those symptoms. One of them is what we call idiopathic anaphylaxis. And those are the patients that would have a severe event where they present lots of those symptoms suddenly. They would even collapse or almost pass out. And that would happen either periodically, once or twice a year, or more frequently. And those patients have been labeled as idiopathic anaphylaxis. And then there would be patients that would have not such severe symptoms, but the constellation of symptoms that would present chronically, almost in a daily basis or in a daily basis. And those patients would not have the classical mediators that we can find in the blood, the classical bone marrow findings. So we are at this point trying to identify and define what is the criteria for those patients to call it as a mast cell activation, either a syndrome or a mast cell activation event. And we are doing a lot of work, myself at the American Academy and with my colleagues at all the other centers, to try to present as many data and as convincing data to put a name to those patients.
Thank you for taking the time to watch this video. We hope you are now better able to recognize the presenting symptoms of mast cell activation. If you are a patient or a physician that has questions about a mast cell disorder, please do not hesitate to contact us or one of our physician specialists. The Mastocytosis Society, producers of this video, is a 15-year-old nonprofit, all-volunteer organization. We're dedicated to supporting patients affected by mastocytosis and mast cell activation disorders, as well as their families, caregivers, and physicians, through research, education, and advocacy. If you or a family member has a mast cell disorder, please consider joining the Mastocytosis Society. Go to our website at www.tmsforacure.org for further instructions, or you can mail a check for $35 to this address: the Mastocytosis Society, care of Regina Rentz, Treasurer, P.O. Box 511, Plainville, Connecticut 06062. Please consider making an extra donation to further mast cell research and education.